Welcome to the learning module for Group 1 Hormone Signaling Mechanisms. This is Dr. Tefke for the Cellular and Molecular Medicines course. After viewing this learning module, students should be able to describe the mechanism of nuclear receptor signaling, describe how coactivators and co-repressors achieve their effects, explain how nuclear receptor agonists and antagonists are used clinically and give examples, explain the clinical aspects of thyroid and glucocorticoid disorders as they relate to nuclear receptor signaling mechanisms, describe the clinical aspects of a loss-of-function mutation in nuclear receptors and give examples, explain the general signaling mechanism for almost all eicosanoids, lysophosphatidic acid, sphingosine 1-phosphate, and PAF, and describe the mechanism by which nitric oxide induces vasodilation and how this is exploited pharmacologically. A large group of intracellular hormone receptors, known as the nuclear hormone receptor superfamily, all bind to lipophilic hormones or lipophilic signals. These signals include steroid hormones like the glucocorticoids, mineralocorticoids, progesterone, testosterone, estrogen, as well as non-steroid hormones such as the thyroid hormones and the vitamin D3 hormones. They also bind to a large number of other lipophilic signaling molecules such as retinoic acids, farnesenoids, and fatty acids. The lipophilic signals that function through the nuclear receptor superfamily all share a similar mechanism of action. They are transported in the blood bound to hydrophobic pockets on serum albumin or on specific transporter proteins. Once at the cell surface, they dissociate from carrier proteins and enter the target cell by simple diffusion through the plasma membrane bilayers. Once inside the cell, the nuclear hormone ligand can bind to the nuclear hormone receptor. Some members of the nuclear hormone receptor family reside in the cytoplasm, while others reside in the nucleus. The hormone receptor complex then interacts with promoter regions on susceptible genes called hormone response elements to affect their rate of transcription. Thus, all the members of the nuclear receptor superfamily function as ligand-activated transcription factors. Since these nuclear receptors function by altering gene transcription, their activity is slow to begin. It can take several hours for a gene to be transcribed and enough proteins to be translated to produce a phenotypic effect in the cell. Likewise, nuclear hormone signaling can be slow to terminate because it takes time for synthesized proteins to turn over and degrade and end the cellular response. All members of the nuclear hormone receptor superfamily bind to a similar set of promoter elements called hormone response elements, or HREs. Depending upon the specific nuclear receptor in question, these hormone response elements are also known as the glucocorticoid response element, or GRE, the estrogen response element, or the ERE, the vitamin D receptor element, VDRE, and so on and so on. All of these hormone response elements are very similar to one another, being comprised of repeated hexameric sequences. Some are arranged as palindromes, which are direct repeats of the same sequence with intervening nucleotide spacers. For example, the glucocorticoid response element is the sequence AGAACA with a 3-nucleotide spacer followed by TGTTCT, which, if read in the opposite direction, is AGAACA. In comparison, the estrogen response element has the similar sequence AGGTCA with a 3-nucleotide spacer followed by TGACCT, which in the opposite direction would be AGGTCA. Hormone response elements with this arrangement are known as indirect repeats. Other hormone response elements are direct repeats. For example, the vitamin D response element is AGGTCA with a 3-nucleotide spacer, AGGTCA again. This is very similar to the thyroid response element, or the TRE, which is the exact same sequence repeated again, except that the nucleotide spacer between the repeated sequence has an additional nucleotide. Thus, the specificity for the vitamin D receptor and the thyroid receptor is only specified by a single nucleotide difference in the distance between the two direct repeat elements. It is not necessary to memorize these response element sequences at all, only to understand the basic mechanism by which receptor specificity is achieved. There are two classes of nuclear hormone receptors. The steroid hormone class bind to hormone response elements as homodimers, and their response elements are indirect repeats. The RXR partnered class of nuclear receptors bind to direct repeats as heterodimers. One member of the heterodimer is always the RXR, or the retinoic acid receptor. All members of the nuclear receptor superfamily share common structural domains, which include a ligand binding domain in the C-terminus, which is a hydrophobic pocket that interacts with the ligand for that receptor, a transactivation domain, which is necessary to modulate the activity of RNA polymerase and thus control the expression of specific genes, and a common DNA binding domain to interact with hormone response elements. This, what's known as a zinc finger DNA binding domain. Zinc finger domains are relatively small protein motifs which contain multiple finger-like protrusions that make tandem contacts within the major groove, usually, of their DNA target. Some of these domains bind zinc coordinated through cysteine residues, but many do not, instead binding other metals such as iron, and some do not bind metal at all. Nuclear receptors do not interact with RNA polymerase transcription machinery directly. Instead, they interact with co-repressors and co-activator molecules to affect the efficiency of transcription initiation. Nuclear receptors can either activate gene expression by recruiting co-activators. Co-activators often have histone acetylase transferase activity. They can repress gene activity by recruiting co-repressors. Co-repressors often have histone deacetyltransferase activity, or HDAC activity. Altering the acetylation of lysine residues in histone modulates the affinity of the histone for the negatively charged DNA. Acetylation reduces the affinity of histone for DNA, making it easier for the transcription complex to initiate transcription from the DNA. Likewise, deacetylation will strengthen the association of the histones with the DNA and keep the chromatin in a less transcription-efficient conformation. Binding of the ligand, in this case thyroid hormone, acts as a molecular switch, causing the dissociation of co-repressors with HDAC activity and interaction with co-activator proteins with histone acetyltransferase activity. The interaction between nuclear receptors and co-activators and co-repressor molecules is modulated by ligand-induced conformational changes in the nuclear receptor. Ligand binding alters their tertiary structure, either exposing or masking protein-protein interaction domains. In this example, the estrogen receptor, which binds to its hormone response element as a homodimer, when bound by its ligand, estrogen or estradiol, undergoes a conformational change that allows it to interact with a co-activator molecule. Solving the crystal structures for the estrogen receptor in the presence and absence of estradiol, a ligand which activates estrogen receptor activity, reveals that a single helix, helix 12, folds back over the hydrophobic ligand binding domain and alters the conformation of the estrogen receptor. Tamoxifen is an estrogen receptor antagonist used to treat some forms of breast cancers. Tamoxifen binds to the same ligand-binding domain of the estrogen receptor as estradiol. However, the tamoxifen estrogen receptor conformation is different than the estradiol estrogen receptor complex. Although the tamoxifen estrogen receptor complex is capable of binding to the estrogen response elements in estrogen-dependent genes, the tamoxifen estrogen receptor complex is incapable of recruiting the coactivator proteins necessary to stimulate gene transcription. Thus, tamoxifen has two mechanisms of action. First, it can compete directly with estrogen for binding to the estrogen receptor, and second, once it forms a tamoxifen estrogen receptor complex and binds to the estrogen receptor elements, the complex cannot recruit coactivator proteins. Here are a few examples of drugs that target members of the nuclear receptor superfamily. Tamoxifen is a member of a class of drugs known as selective estrogen receptor modulators. Another example of a SERM is raloxifene. They both function as agonists or antagonists of estrogen receptors depending upon the cell type and are used to treat estrogen-dependent breast cancers. As we've noted already, tamoxifen can bind to the estrogen receptor, but the tamoxifen estrogen receptor complex is inactive because it cannot recruit a coactivator protein complex. Oral contraceptives, which are combinations of estrogen and progestin, target the estrogen receptor and progesterone receptor, respectively. Antagonists of the progesterone receptor, for example RU486, have been developed as emergency contraceptives. The TZD derivatives, rosiglitazone or Avandia or poiglitazone, Actos, are used as anti-diabetic drugs. TZDs bind to nuclear receptors known as peroxisome proliferator activated receptors, or PPARs. These drugs specifically target PPAR gamma. PPAR gamma regulates genes involved in the control of glucose and lipid metabolism in muscles, adipose tissue, and liver. The glucocorticoid receptor is a target of many corticosteroid medications, including cortisone, hydrocortisone, and prednisone, to treat a variety of conditions. There are several ways in which nuclear receptor ligands can contribute to human diseases. In several cases, there is either abnormal levels, either too much or too little of the nuclear hormone receptor ligand being produced, or in other cases, the nuclear receptor itself is defective. Let's take a look at some examples of each. Since thyroid hormones stimulate oxidative metabolism and increase the basal metabolic rate, too much or too little thyroid hormone production can profoundly affect a person's metabolism. Thiotropium-releasing hormone from the hypothalamus stimulates the anterior pituitary gland to secrete thyroid-stimulating hormone, or TSH, sometimes called thyrotropin. TSH then stimulates the thyroid gland to produce T3 and T4. Thyroid hormones then inhibit the release of TRH from the hypothalamus and THS from the pituitary via negative feedback loops. A deficiency of thyroid hormone production results in hypothyroidism. Hypothyroidism causes a diminished utilization of oxidative fuels, causing weakness, fatigue, and lethargy. Reduced basal metabolic rate leads to less heat production, causing cold intolerance and decreased sweating. Stored fuels are not utilized as much, leading to weight gain. And if the thyroid-stimulating hormone levels are elevated, the thyroid gland itself can become enlarged and a goiter can result. The most common cause of hypothyroidism is Hashimoto's thyroiditis, which is an autoimmune condition causing destruction of the thyroid gland itself. Other less common causes of hypothyroidism occur at the level of the hypothalamus with diminished production of TRH or at the level of the pituitary gland with diminished release of TSH. In either case, treatment of hypothyroidism is accomplished with simple hormone replacement therapy involving oral administration of L-thyroxine. Conversely, overproduction of thyroid hormone, or hypothyroidism, causes accelerated oxidative metabolism, resulting in sudden weight loss, rapid and irregular heartbeats, sweating, nervousness, and irritability. The most common cause of hyperthyroidism is Graves' disease, which is an autoimmune condition in which autoantibodies to the thyrotropin receptor stimulate secretion of thyroid hormones. In other cases, hyperthyroidism can result from tumors that are secreting excess TRH or TSH. These tumors are not subject to the negative feedback loops that would normally inhibit the release of TRH and TSH. Most treatments for hyperthyroidism aim to reduce the thyroid activity and may include ablation of the thyroid gland followed by hormone replacement therapy. Glucocorticoids are another nuclear receptor ligand which is often over or underproduced, resulting in human disease. Cortisol is the major glucocorticoid synthesized in humans. It is released from the adrenal glands in response to stress. It reduces inflammatory effects, suppresses the immune response, and influences metabolism by causing the movement of fuels from peripheral tissues to the liver for gluconeogenesis and glycogen synthesis. As with regulation of thyroid hormone levels, glucocorticoid levels are also under control of the hypothalamus and pituitary. The hypothalamus releases corticotropin-releasing hormone, which stimulates the anterior pituitary to release adrenocorticotropic hormone, or ACTH. ACTH then acts on the adrenal cortex to activate the synthesis and release of cortisol. Cortisol negatively regulates its own production via negative feedback inhibition at the level of the hypothalamus and the anterior pituitary. The negative feedback inhibition of hypothalamus and pituitary signaling by cortisol means that persons on exogenous corticosteroids can become dependent upon them, and they must be tapered off gradually so that the endogenous production of cortisol has time to turn itself back on. Hypercortisolemia is insufficient production of cortisol. This condition is known as Addison's disease, most commonly resulting from infectious disease or autoimmune destruction of the adrenal cortex. The adrenal gland cannot respond to adrenocorticotropic hormone, or ACTH levels, so no cortisol is synthesized. There is also a deficiency of mineralocorticoids, or aldosterone, with Addison's disease. The lack of cortisol causes hypoglycemia and fatigue, while the lack of mineralocorticoids alters the salt balance in the blood and creates a craving for salt. Treatments, again, involve hormone replacement therapy. Hypercortisolemia, or excess glucocorticoids, produce adverse effects on almost every tissue in the body. The movement of fuel from peripheral tissues to the liver produces loss of muscle protein and weakness. Often there's thinning of dermal structures, creating pink and purple stretch marks on the skin. There's deposition of fat in the face, posterior neck, thorax, and abdomen, while the distal extremities are spared. This causes a distinct central obesity phenotype known as Cushing's syndrome. Hypercortisolemia can be caused by pituitary tumors secreting excess ACTH, which then stimulates the adrenal cortex to produce too much cortisol. This is commonly known as Cushing's disease. In Cushing's disease, the circulating levels of both ACTH and cortisol will be high because the pituitary tumor will not be subject to negative feedback regulation by high levels of cortisol and will continue to secrete ACTH, which the adrenal cortex will continue to respond to. Hypercortisolemia can also result from tumors of the adrenal gland that are secreting cortisol, resulting in Cushing's syndrome. The circulating levels of cortisol will be high, but the levels of ACTH will be very low, as the negative feedback inhibition of ACTH production at the level of the anterior pituitary will still function. Yet the main cause of hypercortisolemia is the excessive use of corticosteroid medications. Hypercortisolemia treatments will vary with the underlying cause. While defects leading to the overproduction or underproduction of nuclear receptor ligands are fairly common, defects at the level of the nuclear receptors themselves do occasionally appear. Loss-of-function mutations in a nuclear receptor will produce symptoms nearly identical to that of reduced hormone production. However, in this case, the circulating hormone levels will be normal or even elevated in these individuals. If the loss-of-function mutation is only partial, then these individuals may respond to some forms of hormone replacement therapy. However, if the loss-of-function mutation is complete, hormone replacement therapy will be without effect. A loss-of-function mutation in the glucocorticoid receptor can result in what's known as glucocorticoid receptor deficiency. The inactivating mutation in the glucocorticoid receptor prevent the glucocorticoid receptor from efficiently stimulating gene transcription or modulating gene transcription in response to elevated cortisol levels. Thus, the cells have a reduced capacity to respond to cortisol levels, and the individual will have the symptoms of Addison's disease. However, circulating levels of cortisol will be normal or even elevated, as will ACTH levels, due to the dependence of the negative feedback mechanism on functional glucocorticoid receptors. An analogous situation occurs with inactivating mutations in the thyroid hormone receptor. This produces generalized thyroid hormone resistance. The symptoms are that of hypothyroidism, yet circulating levels of thyroid hormones are normal or even elevated, as are thyrotropin and THS levels, again due to failure of the negative feedback mechanism to function correctly in the absence of functional thyroid hormone receptors. Another well-known example of a loss-of-function mutation in a nuclear receptor superfamily member is the androgen insensitivity syndrome and Riefenstein syndrome, which is a partial androgen insensitivity syndrome. Both of these involve loss-of-function mutations in the androgen receptor. This affects individuals who are genotypically XY or male that develop phenotypic characteristics of female. There are several signaling molecules which, because they are derived from lipids or lipophilic molecules, are classified as group 1 hormones, although they do not signal through intracellular receptors. They actually bind to cell surface receptors to produce their effects. Principal among these are the eicosanoids. Prostaglandins and thromboxanes are very short-lived molecules and act very near their sites of synthesis, so they're autocrine and paracrine signaling molecules. Prostaglandins and thromboxanes all bind to a class of receptors known as G-protein coupled receptors. Leukotrienes are relatively longer-lived molecules compared to prostaglandins and thromboxanes. They primarily mediate the recruitment of neutrophils to sites of inflammation. Leukotrienes C4, D4, and E4 are the components of the slow-reacting substances of anaphylaxis, released by mast cells in allergic reactions. They are responsible for the bronchoconstriction that occurs in asthma patients. These leukotrienes bind to specific receptors, which, like the receptors for prostaglandins and thromboxanes, are cell surface receptors of the G-protein coupled receptor class. Specific antagonists of these receptors have been developed to help control the bronchial constrictions and inflammation in the respiratory tissues. Singulair and Aculate are antagonists of these receptors. There is one known eicosanoid that does not signal through G-protein coupled receptors, and that is 15D-PGJ2, which binds to a nuclear receptor superfamily member, PPAR gamma. Platelet activating factor, or PAF, is synthesized polymorphonuclear leukocytes and by endothelial cells during acute inflammatory responses. It is extremely potent, exerting its effects at very low concentrations. It's a major mediator of hypersensitivity and acute inflammatory reactions. The PAF receptor is also a cell surface receptor of the G-protein coupled receptor class. Lysophosphatidic acid and sphingosine 1-phosphate are two newly discovered lipid messenger molecules that regulate growth-related processes dependent upon cytoskeletal responses. The receptors for both lysophosphatidic acid and sphingosine 1-phosphate are G-protein coupled receptors. Nitric oxide is a gas synthesized in endothelial cells by the enzyme nitric oxide synthase. It freely diffuses across cell membranes of neighboring smooth muscle cells and binds to a cytosolic form of guanylate cyclase, activating it. This results in conversion of GTP to cyclic GMP, a second messenger. Cyclic GMP then activates downstream mechanisms, culminating in reduction in intracellular calcium concentrations and a decrease in the sensitivity of the contractile system to calcium, producing vasodilation. Nitroglycerin is a treatment for angina because it is rapidly metabolized to nitric oxide, which will increase blood flow by relaxing the smooth muscle cells in blood vessels of the heart. The guanylate cyclase isoform that is activated by nitric oxide is a soluble cytosolic form of guanylate cyclase. The other guanylate cyclases are membrane-bound receptors for the ANF factors and for guanylin. Cyclic GMP is degraded by cyclic GMP phosphodiesterases, of which there are multiple isoforms expressed in cell and tissue-specific manner. Viagra, Cialis, and Levitra function by selectively inhibiting the type 5 phosphodiesterase expressed by vascular smooth muscle cells. Since these erectile dysfunction drugs are over 1,000-fold more selective for PDE5 than for the PDE3 isoform expressed in cardiac muscle, they are generally considered safe. However, these drugs are only approximately 10-fold more selective for PDE5 than for PDE6, which is the cyclic GMP phosphodiesterase expressed in the light-sensing cells in the retina. Small overdoses of these erectile dysfunction drugs can cause mild alterations in the visual color perception due to inhibition of the PDE6 in retinal cells. This can cause blue-tinted vision, or cyanopsia. Next is a quiz to test how well you've mastered Group 1 hormone signaling mechanisms.